I wanted to say thank you for joining us today for our cultural competency trainings. My name is Sarah Moore. I'm a project manager at UAMS Northwest for a CDC REACH grant. And what that means is that we are reaching out to the Hispanic and Marshallese populations in Northwest Arkansas and trying to improve access to care and access to health-related resources for both of those communities. So today I will be talking about cultural competency, generally, overall in the healthcare setting, and how best to provide culturally competent care. We'll talk about not only what it means to be culturally competent, but also, the rationale for providing culturally competent care. Why it's important to be able to provide culturally competent care. We'll also talk about the cultural factors that can influence health from people from different cultures. We'll be able to describe the diversity within Northwest Arkansas. We'll explain how culture can influence health behaviors and response to treatment and disease. We'll also talk about key aspects of cultural competence, so what would be, some common traits you would see in someone who's considered culturally competent. We'll also talk about how to communicate cross-culturally, remove barriers to cross-cultural communication. And we'll also perform self-assessments of your own culture, assumptions, and stereotypes, which is a way to mitigate the effects of bias. So I want to start with some background and definitions. Basically first is culture. What is culture? What does it mean when someone says culture? It in a nutshell, it means, it's the breakdown of what makes a person who they are. Officially, it's the thoughts, communications, actions, customs, beliefs, values, and institutions of racial, ethnic, religious, or social groups. And it's not just ethnic or religious or social groups. It's, laws to say social groups, including professional groups and and subgroups such as, if we're talking about healthcare providers, you may be a doctor, you may be a nurse, you may be a man, you may be a woman. These are all subcultures within a main culture. Culture is also something that is learned, and it changes over time. So it's fluid. It's not something you have a culture and it never changes. It adapts as you learn more and more about your surrounding world and are influenced by your surrounding world. It's also passed down from one generation to the next. So when we talk about cultural competency, this is a little bit of a touchy subject. We have debate whether or not someone can truly be culturally competent, because competency implies that somebody has mastered something, and whether or not they can truly master cultural competency is up for debate. Important thing is to start out with what it means to be culturally competent, and so it's a set of congruent behaviors, knowledge, attitudes, and policies that come together in a system, organization, or among professionals that enables effective work in cross-cultural situations. This is kind of the widely accepted definition of cultural competency. In a nutshell, it means being able to interact effectively with people from different cultures and backgrounds. It's a crucial component for providing health care, and it starts from the moment a patient walks in the door. The most important thing to think about with cultural competency is it's not something you achieve. It's an ongoing process, and it involves changes in awareness, knowledge, and skills. And this model, this is Campina Picote's model of the process of cultural competency in the delivery of healthcare systems. So we just wrapped up talking about what it means to be culturally competent. And so I think it's important that we talk about some of the models that discuss or illustrate the concept of cultural competency. There are many models that illustrate this concept, but the best one, the one that is most understandable and most suited to the healthcare setting, is that of Dr. Campina-Picotte. Dr. Campina-Picotte's process of cultural competency in the delivery of healthcare services illustrates how 5 essential constructs are required to develop cultural competency. The first of these constructs is cultural desire. This is simply the desire of the healthcare worker to learn more about a culture different from his or her own. It's a desire to become culturally competent. Cultural desire is the foundation of cultural competency. Without it, it's not possible to be culturally competent. It's kind of like trying to brew tea without any water. The second construct of the model is cultural awareness, which is simply the awareness of the existence of differences in cultures and realizing that your culture and that of your patients isn't always the same. So the third construct, which is cultural knowledge, is the actual process or seeking of knowledge about culture, learning about the Hispanic or the Marshallese or the Indian or the Native American cultures. The fourth construct is cultural encounters. Cultural encounters are one of the best ways to increase your cultural knowledge. You get to have a first-hand experience with the culture. And cultural encounters are the only way to truly break down the barriers that can be formed by cultural differences. And the more cultural encounters you have, the more knowledge you gain, and the more skill, which is our fifth construct, the more skill you obtain. This develops as the provider has that increased encounter with a different culture, particularly with a particular cultural group, and gains more knowledge about that group. Each of these constructs come together, and where they intersect is where you'll find cultural competency. Again, cultural competency is an ongoing process. It's not an endpoint, and if you do not strive to make gains in all 5 of the constructs, desire, awareness, knowledge, encounters, and skill, you cannot truly be competent, culturally competent. And if you want to see an illustration of the model, you can go to the link that's at the bottom of the slide, the transculturalcare.net, and Dr. Campina-Picotte has multiple illustrations of this model. I think the best one she did was in 1998. I think it's the most simple and most encompassing for the healthcare group. So some other important definitions when talking about cultural competency that we need to discuss. First one is bias, and bias is the tendency to believe that some people or ideas are better than others, and it often results in some people being treated unfairly. And bias, which we'll talk about a little bit later, can be both implicit and explicit. And generalization, I think it's important to differentiate between generalization and stereotype. Generalization is a statement. It's based on a limited set of observations and experiences, and yet which claims to hold true for the larger set, even those cases that have not been seen or experienced. You can say that all generalizations are theoretical, and it originates in a rational effort to categorize. As people, we like to categorize things. That's human nature. The difference between a stereotype, though, is it's a mistaken assumption. It's a mistaken categorization. That everyone in a given culture is alike, and it usually originates within or is caused by a history of socio-political struggle. So I'll give you an example. A generalization is all trees have leaves. True most of the time, but if you talk about evergreens, they don't have leaves. I think they have needles. Generally true, and it's not based off of one tree being better than the other or anything like that. Stereotype is such all women are bad drivers. That's a stereotype, and it could say it originates from a masculine society trying to keep women down and not allow them to drive or something. So there's a difference in where it's coming from. They're both a categorization, but generalizations aren't meant to be a way to keep people down. It's meant to be just a way to simplify and categorize for us, because we like to do that. It makes life more easy if we can put things in boxes, because if you have all the information that we do, if you can put it in a box and this is where it's located, this is where it sits, then it's easier to address any new knowledge, any new situations with that particular subject. Excuse me. So I think it's highly important to start talking about the rationale for providing culturally competent care. If we talk about all the definitions, what does it to mean to be culturally competent? What is culture? What is bias? The importance of knowing about these things when it comes to providing care comes down to three basic premises. There's legal requirements, there's quality of care issues and health outcome issues, as well as professional ethical issues. As far as the legal requirements go, it starts with the Title VI of the Civil Rights Act of 1964. This prohibited the discrimination of on the basis of race, color, national origin, and any programs that receive federal financial assistance. And so, based on race, they don't mention language barriers, but that becomes an issue later in 2001 when they developed the National Class Standards, which are the standards for culturally and linguistically appropriate services in healthcare. These really address the linguistic parts of culturally competent care. There are 14 standards. Standards 4 through 7 are actual mandates. These are requirements. It is legally required. It requires healthcare organizations to provide free language services to non-English speaking patients. And Joint Commission mirrors a lot of the class standards. So if Joint Commission comes in and sees that maybe there are language services not being provided to a significant number of your patient population, that becomes an issue. That's a violation of Joint Commission standards. I think more importantly, even more important than the legal requirements, if you're not concerned about legally what you may be liable for, is as a professional, the healthcare professional, the quality of care has been shown to be much higher when you provide culturally competent care. There are decreased rates of hospitalization, higher rates of treatment and medication adherence, fewer health and medical complications, increased patient satisfaction, which is important now that that's becoming a key factor in reimbursement, and we see an overall improvement or a higher or better health outcomes. And finally, professional ethics. As, again, doctors, nurses, social workers, physical therapists, or any other allied health workers, we have all taken some sort of oath to provide the utmost care or the best care to our patients. The classic Hippocratic Oath, it says, "My visit shall be for the convenience and advantage of the patient, and I will willingly refrain from doing any injury or wrong from falsehood." This ties more into what we're going to talk about later, which is bias. You will not explicitly do something to harm a patient or not provide care for a patient based on their race or ethnicity or their social status or any other factor that may be a different cultural factor than something that you are aware of or something that you're familiar with. I'm sorry. So if we've talked about the rationale, we talked about the definitions. It's important to provide culturally competent care, and that's an easy thing to say, but there are things that stand in the way, and it's important to be able to identify what those barriers are. I really like this quote about how we see things. So we don't see things as they are, we see them as we are. That, again, talks to bias. I like to do it here at this point, have people do a short cultural competency self-assessment activity. And this activity will give you an idea of what it means to be able to assess your own cultural biases, assess your own practices as being culturally competent or not. And what I like about this activity is that it's usually an eye-opener for a lot of folks. There are things that we don't realize as being culturally incompetent or not culturally competent, excuse me. But when you do a self-assessment activity, things kind of stand out, and it makes you a little bit more aware. We talked about barriers to cultural competence, so we've got to talk about bias. We're going to play a little game. We're going to pretend that you're moving and you haven't picked a house yet. I'm going to show you some pictures of your potential neighbors. I want you to pick your neighbor. Pick your house based on who your neighbor is going to be. So the first option, we have option A, option B, option C, option D, E, and F. So, usually when I do this, it's in a group, and I like to get people to volunteer from the audience to let me know who they picked or who they didn't pick. So option A, we have Felipe and Enrique Gonzalez. They're brothers. Felipe is caregiver for his disabled brother, Enrique. Option B, we have Randall Bakes. He's a high school art teacher and a part-time model. Option C, we have Rose and Violet. They're sisters, both pursuing master's degrees in nursing and information technology, respectively. Option D is Pastor Bishop. He is in the Army Reserve. He's been deployed once to Iraq and once to Afghanistan. He's married with 2 kids. He's quiet, mild-mannered, and on Sundays enjoys barbecues with his friends and family. Option E, these are Sam and Jacob Bowman. They're brothers who volunteer with a local nonprofit literacy group. And option F is Margie Atkinson. She's a Rhodes Scholar from Michigan, and she's pursuing her master's in theoretical physics. The point of this activity is to illustrate how each of us can see the same image or the same person, but we can still form different opinions based on our own life experiences and biases. While some people look at option A and see, quote-unquote, a gay couple, others look at the 2 and see 2 people who love each other. And still others see 2 old friends. The same thing with option B. Some people simply see a musician. Others see a slightly grungy, slightly gothic guitar player who may be up late, coming home at all hours and practicing loudly in the garage with his band. Others see a pretty cool guy they'd like to know. But this is actually one of his professional headshots, staged by a photographer. He doesn't actually play any instruments. Again, it comes back to that idea. You see an image or a person, and that one instance isn't enough to form a completely informed decision about the person's character or who they are. And that decision we make, that judgment, that opinion or bias that we have, is formed through our own history, our own experiences through our life. We talked earlier about being implicit or explicit. Implicit bias, we don't know that we're being biased, that we're acting on bias. And a common example that they have found is African American men who are being seen for hypertension are roughly 24 to 27% less likely to receive a prescription for antihypertensive medications. Why is that? Lots of studies are looking at why. This is implicit bias because a lot of times doctors aren't thinking about, this is an African American man. Well, I'm not going to give him medication. There's no doctor out there usually that's going to tell you that's what the case is. Explicit bias, that's that definitive, purposeful, you might as well say that's prejudice. That's a bias that's overt, and there's nothing unconscious about it. Implicit bias is becoming more of a research issue because they've realized how much of an impact it has on the provision of care. And so self-assessment, we talked about that self-assessment earlier as a method to challenge bias. It's a way for you to say, what am I bringing to the table? What are my experiences in life? How are these affecting my views or my interactions with my patients. And it's also a way to be able to look at how much of the interactions with people from other cultures you've had, and be aware of these things that you may not have any idea influence your patients in terms of their comfort level in your clinic. It brings it to your attention that, oh, I never thought about this because this is where I'm coming from, but they're coming from here and this is how they see it. I think one of my favorite examples of this is, when I talked recently to a pediatric clinic and went in and we were talking about health literacy and culturally competent care, and they were very, very interested in providing better care for their Marshallese patients. They really wanted to be able to reach them and improve care on a whole for all their patient population, but specifically their Marshallese population. And the first thing I noticed in both, they had 2 lobbies, 2 waiting rooms. All the pictures of the babies in this pediatric clinic were white, and there was one brown-headed baby, but they were still white, and the rest were blonde, blue eyes. But they had a 25% population of Hispanic mothers or expecting mothers, and about a 10 to 15% population of Marshallese mothers. So that simple thing of walking into a clinic or a waiting room and seeing pictures of people that look nothing like you becomes an issue. It immediately kind of sets up a closed door policy. They don't feel as open or as welcome in that setting as they could. So talking about Northwest Arkansas and the cultural competency, here in the healthcare system here, it's important to know what kind of populations we're treating in Northwest Arkansas, or what type of populations we're likely to see. And in Northwest Arkansas, we've had, in the last 25 years, the Hispanic population has increased from approximately 1% of the population to 16% of the total population, and actually quadrupled between 1990 and 2000. Northwest Arkansas is also home to the largest Marshallese population outside the Republic of the Marshall Islands and Hawaii, with approximately 11,000 individuals living in Springdale. The total population of Marshallese within the U.S. has actually tripled between 2000 and 2010. The African American and Asian populations have also increased significantly in the last 15 years. And this is only the racial and ethnic makeup of Northwest Arkansas. We talked earlier about subcultures. We think about, there's college students, there's retirees, all the people in between that are still working. There are blue collar workers, there's white collar professionals, there's business professionals, healthcare professionals, and on and on and on. So this is just looking at the racial and ethnic makeup of Northwest Arkansas. And specifically with Washington County, what this graph shows is an actual breakdown of the minority populations. You can see that Hispanic population composes the greatest proportion of minority populations, and then it's followed by African Americans, Asians, Native Hawaiian or Pacific Islanders, and then Native Americans. What I like about this graph is comparing it to the following graph to Benton County. So we've got Washington County, Washington County and Benton County. Benton County, obviously, both still have Hispanics that compose the highest proportion or significant proportion of their minority populations. You can see the difference. One of the biggest differences is the Native Hawaiian or Pacific Islander populations. In Washington County, you've got a more significant number of Native Hawaiian or Pacific Islanders, and that would be a lot to do with Springdale and where the Marshallese population lives. And so looking at the breakdown of the various communities in Northwest Arkansas, we've got to look at what it really comes down to: providing care to people from different cultures, specifically cultures where English maybe not be the main language or primary language spoken. The number of non-English speaking or English as a second language people has nearly doubled in the U.S. in the last 30 years, and approximately 20% of Spanish-speaking Latinos say they do not seek medical advice due to language barriers. So the language barriers are probably your number one barrier to being able to provide culturally competent care. And there's some things you can do to limit those or to overcome those. First, if you're talking with a patient who has limited English proficiency, and this is someone who wants to speak English or can speak enough English that they want to communicate in English, you don't have to use an interpreter if you feel like they are comprehending enough, and that's something that's their wish to communicate in English. Go ahead and do it. Important thing is to know is you want to repeat your important information. They're going to pick up on, they've said this now 3 or 4 times, this must be important. You want to give it information in small increments. Don't overload them or overwhelm them with information. Let them absorb it and then move on. And ensure your patient understands before moving on. And that ties in with the teach-back method. Is not simply asking do they understand. Nodding is not an indication of understanding in most cultures. It's often a sign of yes, go on, or it's a sign of politeness. It's not necessarily means I get it. So have them teach back, give them a small amount of information, get them to repeat back to you those main points before moving on. Speak slowly, not loudly. English is their second language. They're not hearing impaired. And education materials. This is a big one. A lot of folks say, well, I don't have something to give them in their primary language. I shouldn't give them anything at all. And that's not true. Oftentimes, somebody, if you don't have documents in or materials in their primary language, provide it to them in English. They often will have somebody at home or in a church group or in some other social group that will be able to help get them through, read it to them and interpret it for them. And then if you determine that your patient doesn't comprehend enough English to be able to speak in English with them, or they don't speak any English and it's clear that you will need an interpreter, it's important you remember that you must use an interpreter. There's the legal requirements and ethical requirements and the whole healthcare outcomes tend to be better when you have good communication with your patient. So ideally, your first choice is to use a certified interpreter. You can either do face-to-face, which is the ideal of your 2 options, which is face-to-face or telephonic. Face-to-face interpreters, you are able to observe the nuances that happen with interaction, with communication, all the nonverbal cues that occur in all cultures. Telephonic would be your next option because you may not have an interpreter in your clinic or in your hospital practice. This is very true here in Northwest Arkansas with Marshallese patients. We're seeing more clinics, but still not enough clinics or hospitals that employ Marshallese translators. And this is an issue which will be talked about when we go into the Marshallese cultural competency training. So your first option, you've got certified interpreter. Your second option is non-certified interpreters. And that's going to be, a staff member, maybe that's, not trained to be an interpreter. So it could be a food service worker, housekeeper. It could be a tech, a CNA, but not necessarily been trained as a certified interpreter. It could be a nurse, but a nurse, again, unless they've been through a certified interpretation program, is not a certified interpreter. So that's your next level. And then finally, and we all know that this is not ideal. JCO doesn't, or Joint Commission does not approve of it. It's not ideal. Sometimes it's the only option. Is you use the person accompanying the patient. The only time I would say this is definitely never really an option is if it's a child. This is something we've been asked several times in other trainings is what if it's a child, that's the only person? Well, you need to find a blue phone or a face-to-face interpreter, because not only do you have the issue of non-certification, but you have a different education level, and you have cultural differences where children, there are things that they cannot discuss with their parents, even if they were to understand it. So That's your last option for being able to communicate with a patient that does not speak English. I do want to take a second to talk about a third option as a source of communication with patients that don't speak English. Community health workers. Community health workers provide a linkage between traditional healthcare model and underserved communities. They may serve as a lay or peer educator. They may be a member of your care delivery team. They may be a care coordinator or a manager. They may be a health educator, an outreach or an enrollment agent. They may be a community organizer. These are people from the community with which you are trying to reach, and they're able to bridge that gap. They have enough experience within the healthcare setting that they can help not only patients but providers and provide that information and cultural awareness and knowledge for doctors. So that'll help increase their cultural skills and their cultural knowledge and overall cultural competency. So some things to think about when using interpreters. It's not as simple as, okay, we do need an interpreter. We've got the interpreter. Let's just go and do this. There are some best practices to think about when utilizing interpreters. The first of being, I had someone ask me about this the other day about explaining to the interpreter what information you were trying to convey. So things don't translate always easily from English to this other language. And if you can give the interpreter an idea of what you're trying to get from the patient and what you're trying to make sure they understand, it will help in the overall interaction with the patient and the interpreter. So have that little powwow, a minute or two before you go in, or when you first come into the room with the patient. But make sure you both understand, or your interpreter understands what you're trying to send, the information you're trying to send to your patient. Greet your patient first. That's the other thing. We know some cultures eye contact is not, it's not ideal. It's not considered actually polite. So you don't want to sit and stare at your patient. But we also know that acknowledging your patient is important, no matter what culture they're from. Even if it's brief eye contact and a nod of the head and a smile, it goes a long way. It lets the patient know that you see them. And when you communicate, speak in first person, rather than saying, tell her that she needs to take this medicine at this time. You need to take this medicine at this time. What is bothering you? Why are you here today? Not what brought her in today. It, again, lets you have more of an interaction with your patient. And you speak directly to your patient. If you put your interpreter a little bit behind into the side of your patient, you can have that one-on-one dialogue easier and more naturally. And again, it's going to include the patient to where they don't feel like they are a third party in their own care. Note your patient's body language. If they are looking uncomfortable or scared or confused, they likely are. And so pick up on these cues and use your interpreter to figure out what's going on. Ask one question at a time. That's a big one. Allowing the time for the interpreter to interpret, for your patient to answer, and your interpreter to interpret it back for you, rather than rushing through more than one question can become confusing and you don't get the true answers you're looking for, or the true answers you're seeking. Pause often. This kind of goes along with one question at a time. If you rush through the interpretation session, it's harder for the interpreter to interpret. And again, the patient is going to feel excluded because they're rushed and don't have that time to really fully communicate what is going on. Don't interrupt your interpreter. Again, let them interpret, let the patient respond, and let the interpret again, because you're not going to get a full answer if you interrupt your interpreter. Provide explanations of technical terms. So this is something I think that's true in all cultures, whether someone speaks English or not. Health literacy levels are relatively low in this country, and we have a tendency to use the technical terms, and well, even if someone doesn't speak English, or if they do speak English, sometimes they don't understand what you're saying. So being able to break things down in a more simplified manner is very important, so your patients have that understanding. Don't use double negatives. It's confusing. Be aware of gender differences. This is really important in some particular cultures, and the best practice would be to use female interpreters for female patients and male interpreters for male patients. Ask your interpreter's opinion. Is the patient understanding? Does the patient seem confused? Do you think the patient has everything they need to be able to take care of this, or take this next step? And respect your interpreters in judgment. So if your interpreter thinks, I don't think they understand, go back and explain it in another way. And taking all those into consideration, all those considerations for using interpreters, you may want to consider scheduling more time when you have non-English speaking patients and you're going to have to use an interpreter. And we had a question in one of our last trainings about, well, won't this take up a lot more time, and can we really justify this? And the answer is yes. The more you do this and more proficient you become at it, the less time it's actually going to take, and it's going to become more fluid. It's become second nature, and you'll end up saving a lot of time with unnecessary follow-ups or unnecessary follow-ups due to medical complications because treatment adherence was not ideal. So it's important to talk about, how culture affects people's view of health and how they approach health, how they look at health. And so we like to look at that connection between culture and health beliefs and behaviors. We know that culture can influence a person's belief in a cause of illness. And we'll hear more about that some with the Marshallese and Hispanic cultural competency trainings. As professionals, we tend to think it's due to an illness or a chronic disease or an infectious disease, and that's the only answer, but that's not always the case of how your patient may be viewing it. Culture can also affect someone's perception of illness or their disability or a health condition, which is going to affect how they address it, how they choose to treat it. And so some examples are pregnancy or aging, death, and dying. Culture also influences a view of treatment or medication adherence, and it also influences a sense of responsibility toward health. You can see this in a lot of cultures, and the idea of preventative care is not something that is common in all cultures. And you can also say it's not been a high priority sometimes in the U.S., in the U.S. culture, the American culture, but it's becoming more and more prominent, understanding the idea of doing things to take care of yourself to avoid getting ill. And finally, culture can alter or influence a person's view or perception of a healthcare provider. So simply being from a different culture, the way your patient may interact with you could be totally different than they would any other person from a similar culture. So it's important to talk about theories of health and illness. So I talked earlier about, we think as doctors and nurses, we may want to say that germs or chronic illnesses are the reasons people get sick. I think it's important to look at some other possibilities where your patients may be coming from, specifically personalistic theories. These are illnesses linked to a person's misbehavior. You've done something wrong, and so you are sick because of it. You either you're cursed or it's your punishment. You'll often see healers consulted. Naturalistic theories, health is viewed as a state of harmony between the person and his or her environment. Illness is not due to, it's impersonal. It's not due to anything you did right or wrong. It's just a mechanistic cause. Germ theory, that is, the idea that microorganisms are the cause of many diseases, and it's a primary health theory of contemporary Western medicine. And fatalism. Fatalism is not necessarily a theory of health or illness, but it can influence a patient's approach to health and approach to healthcare. It's the belief that events in life are out of one's personal control. So, fate or God's will or karma And it's not again, as I said, not necessarily an explanatory model of illness, but it obviously would affect someone's health behaviors if they felt that God or karma was to blame, and they don't feel like they maybe have an option to act upon as far as treatments go. So bridging the gap between providers and our beliefs and the beliefs of our patients. If we are on one side saying you're sick because your diabetes is out of control, and your patient is on the other side and thinks they're sick because their neighbor cursed them, your approach is going to have to be a little bit different. You're going to have to be able to meet them halfway and negotiate with them. So some cross-cultural communication and interviewing skills. So when you talk with patients where you may have a feeling that they are not looking at it from the same direction you are, the things you can do to mitigate any miscommunication, and you ask questions. Be curious. As a provider, you're going to need to know a lot of personal information, and that's okay. Ask the questions, be curious, and with different cultures you may want to explain why you're asking these questions, but the important thing is to ask them, and don't be afraid to. Listen to your patients. If they are hesitant or maybe going a long way about telling you about why they think they're sick or what's going on or how they came to be sick, be patient. Listen empathetically and listen actively. Ask more questions if you hear something that you need clarification on. Use appropriate language. So this goes back to trying to talk in lay terms. Try not to use too many technical terms, and don't use judgmental terms. Right, wrong, good, bad. Those are things that can immediately shut down communication with a patient from a different culture if they feel like maybe you are not approving of some of the actions they've taken or the way they're viewing things. Get clarification, going back to ask questions. So if you're not sure about something and you want to know more about it, ask. Offer opportunity for feedback. Let your patient talk to you about what's going on, what they're feeling, what they're worried about. Do they understand? And make sure you guys are both on the same page. And then finally, you want to negotiate. This comes down to if your patient is on one end of the spectrum as far as what they're viewing as the cause of their illness, and you're on the other end of the spectrum, how can you meet in between? Maybe they want to go ahead and use some herbal remedy that their shaman has given them to help break their fever. As long as you know it's safe, there's probably no reason not to let them take it. You may want to add in, I would also like to try this because I think it may have an effect, and it's an antibiotic or something. But rather than saying no to their suggestions, unless it's life-threatening or you're afraid it might cause trouble, cause death or disability. Some things to think about when you do cross-cultural communication or have a cross-cultural communication interaction. There's lots of mnemonics out there that talk about how to go about eliciting this information from patients. And, some of them, you may have heard the adhere technique, diverse, bath, ethnics. These things, such as, adhere, it means acknowledge, discuss, handle, evaluate, recommend, or empower. Diverse means demographics, ideas, views of healthcare treatment, expectations, religion, speech, environment. All of these mnemonics, if you look up these cross-cultural mnemonics, they all have something in common, and it has to do with asking these patients these questions, figuring out where they're coming from, being able to negotiate and provide a solution that both parties can live with, that both parties find ideal. So some characteristics of culturally competent individuals. I talked earlier about what it means to be culturally competent, and if you want to say, how do I know if I'm culturally competent? Ask yourself, do I ask questions? Do I seek answers? Do I learn from my mistakes? I think this has a degree of humility to it. Everyone makes mistakes. We're humans, and if we don't learn from our mistakes, our mistakes can be one of our best teaching moments. It can be one of the best opportunities to learn and grow. And so be willing to acknowledge if you've made a mistake and learn from it so you don't do it again. Know your limitations. So again, a degree of humility. If you don't know something, don't pretend that you do. Find someone who does. Challenging discriminatory behavior, stereotyping. Do you do this? This is something that can be hard. If you see or hear something in your practice, whether it's in a hospital or clinical setting, that you know is wrong, is discriminatory, it's kind of the idea of confronting a coworker about that can be intimidating. But if you can do so, particularly in a I'd say a politically correct way or a sensitive way, you've not only stood up for what you believe in, but you've also maybe made an influence or had influence in your coworkers' outlook, which means their treatment of patients from different cultures may be different. And do you engage your patient? Do you let your patient sit and nod questions, or do you really try to get those patients to tell you more about what's going on in their life and what's going on with their health, and utilizing that information to influence to change your treatment? So in summary, I want to talk about the main points to take away from the general cultural competency. Cultural competency is a process. It's not an endpoint. That's, I think, the number one thing to remember. You will not wake up one morning and say, I'm culturally competent, I don't have to do anything else for this. You will always need to be learning and be willing to learn, and utilizing that information that you've obtained and to provide the best care to your patients. Also, our experience and our culture, our influence how we interact with each other and how we view health, and how our patients interact with us and how they view health. So be aware that our culture has influence on our interactions with people, and that's where the bias can come in. It could be implicit or explicit, and oftentimes in healthcare it's implicit. We don't know it. It's there, and the best way to challenge this is through self-assessment. You ask yourself, what are the things that I do that are culturally competent? Where have I come from? What have I experienced? How is this affecting my take or my view of this person in this moment in this with this case? And then communicating effectively across cultures. It requires patience. It requires respect. It requires curiosity. You want to approach every encounter with respect for the other person. They're always a person before they are an African American person or a Muslim person or a LGBT person. They're always human before that. Be curious and be aware that your perceptions can be influencing your culture, that your experiences can be influencing your perceptions of the situation. And finally, be aware that it's not necessarily what you say, but how you say it. Again, nothing is necessarily taboo, but being able to explain to patients why you're asking questions or suggesting what you're suggesting, it provides some empowerment for your patient and lets them help have that influence in their care. And finally, there are some of our references and resources for our presentation today. One of the takeaways I like everyone to know about is the Harvard implicit bias test. You can find that at implicit.harvard.edu, and this is an amazing tool. I took it. There are so many different exercises you can do, and it tests for implicit bias. You can't fool it. And so male and female gender roles, I'd say the one I took was African American men and dangerous weapons, and whether I had some sort of implicit bias toward African American men when it came to violent weapons. I think it was guns and bombs. I can't remember for sure, but there were half a dozen or 6 to 10 different tests you could take, and it's kind of an eye-opener saying, hey, I have no bias, or I did have bias, and knowing that lets you take the next step. So I do highly recommend that for anyone who is interested in it.